I'm going to talk about general treatment of Krabbe disease. These are my disclosures. I'm happy to discuss later if anybody wants to talk about it. Since cord blood transplant has taken a major role in being the donor source for transplant for babies with Krabbe disease, I just thought I'd take a minute to remind you of the history of Krabbe disease, of cord blood transplant, which started in the mid 1980s when Hal Broxmeyer, the guy sitting on the left, discovered that there are blood stem cells in cord blood, the baby's blood left over in the afterbirth, which is generally discarded as medical waste after a baby is born. And you can collect it and store it under liquid nitrogen for decades, and those cells will remain viable. We now know cord blood cells also have a higher propensity to repopulate microglia after they're destroyed by chemotherapy. And so for many reasons, it may be the best donor source for a disease that affects the brain. The theory that cord blood contained blood stem cells was tested in 1988 in a little boy with Fanconi anemia, shown in the middle picture with Elian Gluckman, who did the transplant at Hospital St. Louis in Paris. And in the day, Elian really invented reduced intensity transplant because you needed to do reduced intensity for a Fanconi patient to tolerate chemotherapy. But we didn't really know that. We didn't call it that in the day, but now, 30 years later, that's what happened. Hal flew the cord blood, which was collected in a very small town in North Carolina when this kid was born, and stored in his freezer at Memorial Sloan Kettering to Paris. And it was infused, just diluted 1-to-1 with DMSO and media. So it was a huge volume. And the kid had an infusion reaction, but long story short, he engrafted by about day 18 and did well. And he's alive and well now, 35 years later, actually 37 years later. He's shown in a picture with me a few years ago, doing well. And I think he's now the longest surviving Fanconi patient post-transplant because they still do develop malignancies, particularly squamous cell carcinoma. He's been lucky. That has not happened, but it's a potential risk even with transplant. More importantly, his blood is his baby sister's blood, and his cord blood cells have durably engrafted and maintained hematopoiesis all these years, and there's really no reason to expect they won't do that for his entire lifespan. That paved the way for cord blood transplantation, which has had its own history, and I really won't go through everything, but we did the first unrelated transplant in Duke in 1993. There is now a federal program called the National Cord Blood Inventory that subsidizes public cord blood banks in the US. There are 5 active licensed cord blood banks, licensed by the FDA, which is a requirement for public banks these days. There are somewhere between, that's a typo, 4,000 to 5,000 unrelated donor cord blood transplants performed annually around the world. And cord blood is emerging as a source of cells for other cell therapies and regenerative medicine. Now for Krabbe, you've heard the background. We all know it's a disorder of brain myelination. Last count, I think there have been over 300 mutations described. And with newborn screening, I think we're learning more and more. There are variants we didn't know anything about that can be disease causing, particularly if they're in combination with known disease causing mutations. Classified by infantile, which means onset of symptoms under 12 months of age. And that's what we now call the infantile form, used to be called the early infantile form. And that is what we are screening with psychosine greater than 10 in newborn screening that you heard about this morning, greater than or equal to 10. This form, which is the most common form, progresses rapidly. And unless it's treated in the first month or so of life, at least transplant is not effective in sufficiently rescuing the patient. And it's looking early on like gene therapy is also going to need to be administered early. There's a late infantile form, presenting between 1 to 3 years of age. Generally, has less rapid progression, but is also fatal. And when we were talking about cycosine between 2 and 10, that we think is the form that sometimes presents with that cycosine. Then there are juvenile cases which have much slower progression, and we don't really know if their cycosine is elevated at birth or not. I think not personally, but it's not elevated when they present clinically, and the adult form, which has the slowest progression. And treatment varies by type, level of disease activity, and in general, it's a parental choice. And we didn't say it in the conversations we were having before, but I think it's really important not to be judgmental, not to be paternalistic, um, and that's something you have to, I think consciously about. Families have a very difficult choice to make, and they have the right to make the choice they need to make. I believe our job is to give them the knowledge they need to make the choice they're going to make. Time of diagnosis can be in utero, particularly if there's a family history of another affected child around birth when newborn screening, or at the time of a sibling's diagnosis. If a sibling presents with clinical symptoms, you should always take a family history, know the biologic parents, and then screen other individuals in the family. We all know about newborn screening. One thing that's happening now, which to me is very disconcerting, is pregnancy screening. So families, the mom's pregnant, and the OB says, oh, we got this great panel of extended testing I can do. You can buy the one that's 180 tests. It goes all the way up to 500 and something tests. And then you find out mom's a carrier. And then they test dad, and you find out dad's a carrier. And then you're 15 to 20 weeks into the pregnancy, and you have to make a decision of, do you test the fetus or not? And will you make a decision about what to do with that pregnancy if you know the results of the test and the fetus? And it just all gets very complicated. I personally wish we did preconception screening, kind of like they do in New York for Tay-Sachs. I know you can't force people to do that, but at least OBs could talk to young women about having that opportunity, because preconception, you have an option to do pre-implantation diagnosis, embryo selection, other things that could create a pregnancy that is not affected by Krabbe. So we all know for diagnosis in the infantile form, the cycosine is greater than or equal to 10. It's generally much higher, although you just saw this baby had a cycosine of 15, which is the lowest I've ever seen in an infantile case. Before that, it was 24. And the cycosine can be higher, even over 100, depending on the baby. Again, there's many mutations described. For kids at risk for later onset, Krabbe disease, the cycosine, we think, is between 2 and 10. I'm going to ask Joe, but I'm not aware of a case of true late infantile Krabbe disease that had a cycosine under 5, but it's something we want to look at. You don't know? Yeah, you agree. I mean, because that could really help guide how you manage cycosine when you get a result in the newborn screening lab. We all know how babies present with poor feeding, failure to thrive, irritability, spasticity, seizures, blindness, constipation, and developmental delay. And many, many, many families go through a diagnostic odyssey, if there is no newborn screening, of being misdiagnosed or, referred to GI doctors for colic or this, that, and the other, until they actually are several months old and somebody does an MRI and sees the white matter disease. And of course, that's too late. So diagnosis is made by GAL-C level, cycosine, and mutation analysis. And depending on where you are in that pathway, if you know it's infantile Krabbe disease because cycosine is high, although you will do mutation analysis, you don't wait for those results. You move forward with options for treatment without waiting for that information. You've heard kind of through Rob's workup, babies need an MRI, an EEG, a Bayer, a VEEP, nerve conduction studies, CSF protein. We also get CSF cycosine now, neurocognitive testing or an examination in a newborn, and a good physical examination and medical history in the family. I will say the baby that you just presented was a beautiful baby, very normal looking. Unfortunately, had a broken clavicle broke its clavicle during delivery. So I had one arm that didn't move too well because of that, but just, neurologically otherwise was completely intact. So the treatment options are hematopoietic stem cell transplantation, gene therapy, supportive care, and palliative care. And supportive care and palliative care have different definitions and different practices, but they are the care that you would give to that child to maximize their function and maximize their quality of life for as long as they live. And it is true that that's sometimes very hard to provide, very hard to fund. I think it's what the Leukodystrophy Care Network in part is about. But to actually operationalize that is not always easy. So in all babies, regardless of what treatment they otherwise select, you have to do things to minimize spasticity, which includes physical and occupational therapy, sometimes Botox, sometimes baclofen. You have to watch bone health, because if these babies don't have gravity, go in a stander or whatever, they're going to get, spontaneous fractures. They may need biphosphonate therapy. They need pulmonary support with chest PT, vests, bronchodilators, etc. They need their GI health managed for reflux, for constipation. And in the babies we transplant, which I'll come to, we always put in a G tube because it just helps with their management. It's not because they're not going to eat by mouth eventually, but it just takes the pressure off getting to be able to use the gut. You need to recognize, treat, and prevent seizures. You need to treat pain and irritability. Drugs like methadone, I've found, really are effective in helping these babies with what may be pain that they're experiencing. Ativan is very good for the irritability. Neurontin and Klonopin are used in combinations by many of us treating these babies. And then schools, psychological support, et cetera, will come later on. When I made this slide, gene therapy was experimental and still is. And there were 3 companies in the gene therapy space: Passage Bio, who did initiate a phase 1 trial giving AAV vector into the foramen magnum. They treated 1 trial and then closed the study, not, as someone said this morning, not for toxicity, but just because they didn't have resources to invest in such a rare disease. Forge is the viable gene therapy study now, and they have an ongoing phase 1 clinical trial, and their therapy is IV AV10 given post-transplant, and there's a wide range of when it can be given post-transplant. The study is just about to start their second, or they had a high and a low dose level. They finished low and they're starting high. It's 1 child at a time, and there's waiting periods between children. So you can't just say, I want gene therapy, go. That doesn't exist yet. And then Neurogene was developing a different viral vector gene therapy, again, into the foramen magnum, but they abandoned the program for financial reasons, which, so they never got it into the clinic. Transplant, we all know, is effective if it's performed in the pre-symptomatic state in infantile disease or early symptomatic state in older children with late infantile or juvenile Krabbe disease. For the infantile Krabbe disease, it really needs to be performed in the first month or so. That affects survival and functional outcomes. Transplant is, it's difficult, it's complicated, it's risky. It's a lot for the family to go through. And as was said this morning, this is usually a mom who just had a baby who has to make all these decisions very quickly. So it's really a lot of unfortunate circumstances that are piled up together. But generally, kids are in the hospital for 2 to 4 months. That includes their workup and identification of the donor, placement of a central line or lines and a G tube, administration of high-dose chemotherapy, bone marrow aplasia, which can last for generally 2 to 4 weeks, recovery, which includes early engraftment, but then full engraftment and recovery of the immune system, which I really think takes 12 to 18 months. And there are risks of treatment of transplant-related mortality that have nothing to do with Krabbe disease, like infection, organ failure, or ongoing graft versus host disease, where the donor cell attacks the baby and causes another syndrome that requires ongoing immunosuppression and treatment. Supportive care is complicated and includes the lines, the G-tube, transfusions, antibiotics, seizure prophylaxis, either parenteral or IV, enteral or parenteral feeding, IVIG, PTOT, speech therapies, lots of things that go on for many months. And again, the risks are graft versus host disease, infections, veno-occlusive disease, which is a toxicity in the liver that can cause liver failure, other organ failure, graft failure, or death from the procedure. And overall today, the risk of death that I tell people is 10%. And this is unrelated to Krabbe. It's just going through a transplant as a young baby. Special considerations for babies with infantile Krabbe disease undergoing transplant. So you've heard again and again how important rapid diagnosis is and how cytosine has facilitated that. Again, I'll say don't wait for mutation analysis. If you're referring the baby for transplant, you have to transfer the baby off mom's insurance. Babies, when they're born, for the first 30 days of life, can stay on their mom's insurance. But if you need approval for evaluation or treatment for transplant, you have to have your own insurance. So somebody has to remember to transfer the baby off the mom's insurance. Refer to a transplant center for workup. I know Rob did an incredible job, but he's a special guy who knows the disease and knows what's got to get done and made it happen. But a lot of times in a center, like there was a kid I talked to the family a few weeks ago from Idaho, where their local center just really did not know what to do or how to do it. And then it slowed things down. So in that kind of setting, they need to get to a transplant center. And I generally admit for workup. You can start chemotherapy before you've identified your final cord blood donor, as long as you screen and identify several units that are possible donors. You can do a search once you have had HLA typing. It takes 10, 15 minutes for the search coordinator to do the search. Then you can select units for further workup, which includes what they call HLA confirmatory testing and GAL-C levels. David Wenger's lab will perform the GAL-C levels on a segment of the cord blood unit. And they will do it out of their normal cycle of Thursday testing if you ask them to, just to make sure you're not selecting a carrier of Krabbe. The HLA-CT typically takes 5 days to come back. Then you can place the G-tube in the central line during the same surgery. You should start chemo in spite of newborn jaundice. And you can start the chemo without actually finally selecting the cord blood unit. And I want to put 2 timeframes in your brain. One is when a baby's diagnosed and you do the information transfer to the family and you refer to a transplant center, there's still going to be another week or 10 days that that center is working up the baby, placing the lines, getting all this stuff we keep talking about done. So if somebody wants to change their mind, they can. But after the first dose of chemo, you shouldn't change your mind. And so, but I'm saying you have a little more time than you think you have for that family to make this very quick decision. But once they start chemo, then you're really going and it's too late to change your mind. And I explain that to families and referring doctors all the time. Okay. So I'm going to go through the reports of the history of using transplant for Krabbe disease, and it's kind of got a story with it. So the early transplants in newborns who had Krabbe disease were done because there was a family history of an older child who had been affected, and then the parents knew to screen the subsequent pregnancy or to screen that baby at birth. These are in the very early days. And I'll show you the data in a minute. But in the very earliest days, we we didn't know that if you took a symptomatic baby with Krabbe disease and transplanted them, that they wouldn't do well, that they would not regain neurologic function they had lost at the time we transplanted them. Once we learned that, we changed practice. But in the early days, we really hoped we could take an 8-month-old, 9-month-old who was very symptomatic and transplant them and fix them. And that does not work. When New York started newborn screening, which is now like 18 years ago, right? Yeah, I have to look at Joe. That there also was an experience with the first 5 babies identified that was published by Wendy Wasserstein and wasn't great. And then we updated that in 2020 with a group of us reporting the first 6 babies who were diagnosed through what I'll call more modern newborn screening. And I'm going to talk about both of those reports. So the first report was done by Maria and I and a cast of many other people and published in the New England Journal in 2005. And here we had 2 groups of babies, 11 who were diagnosed because of a family history and a transplant in the first month of life, and then another 14 who presented symptomatically and were transplanted generally between 3 and 10 months of life. You can go back to the paper and see their mutations. In these days, we did not have cytosine, so I can't tell you what their cytosines were. But the theme here was a group of babies who were identified in the first month of life against an asymptomatic, and a group of babies who were symptomatic and identified because they presented with symptoms. And they all got cord blood grafts and all engrafted. And their outcomes, I will show you, are mostly important because of their neurologic development post-transplant. So it happened in this group of babies. We had 100% survival. That's unusual. Usually it's more like 90, but we did. And this just shows you survival curves between the asymptomatic babies on the top who all survived, and then the symptomatic babies who over time died of not transplant complications, but complications of poor neurologic function like aspiration pneumonia, seizures, infection, things like that, that they couldn't clear, compared to an untreated control group who also all died, but at a little bit slower pace than the symptomatic babies. Dieter showed this slide this morning, but this just shows comparison of the babies who had affected siblings and onset of symptoms of the siblings or death of the siblings in the darker lines, and the survival of the transplanted kids in the lighter lines, just showing that transplant definitely extended survival. More importantly, transplant affected development, and that was almost exclusively in the pre-symptomatic babies. So the colored lines show you development over time, and this is, I think, a 6-year curve. The colored lines are the babies who were pre-symptomatic at transplant in the first month of life, and the black lines, which are kind of all piled on top of each other at the bottom of each graph, show you the symptomatic babies and their neurologic outcome post-transplant. And what you can see is that babies transplanted early and pre-symptomatically had pretty normal cognitive development, a lot of adaptive behaviors, good receptive language and expressive language skills, still had some gross motor impairment, which varied from baby to baby. And in fact, I have a pointer. The kid who's right here, you can see that, is now 21 or so, in college, drives a car, walks around. And she's a homozygous 30 kb deletion whose sister died when she was 3. So I don't think we know enough about the genetics yet, but just to mention that patient. But the take-home message here is all the symptomatic kids did not develop neurologically. They did not regain any function, and they had very poor neurologic outcomes. And because of this, I know in our center, and I believe in many centers, we stopped transplanting symptomatic kids. As painful as that is to have to talk with the family, there is no point in putting them through a transplant for no benefit. Now, Maria published a 15-year study and follow-up of some of these same kids in 2017. And basically, I'm just going to go here, showed the same curves and two themes. Their cognitive development at 15 years was pretty normal. Their gross motor function at 15 years had deteriorated. That's the bottom graph. And for the most part, the big contributor to this was progression of peripheral neuropathy, which both in this disease and MLD does not appear to be corrected by hematopoietic cell transplantation. I was very encouraged to see in the dog experiments with gene therapy that it does appear, if you give gene therapy very early, that it may favorably affect the peripheral neuropathy, but we still have to prove that in human. And this was the survival curve of those 15 patients with about 80% surviving out 15 years. We published a similar article, a couple of them showing late outcomes in another 27, or I'm sorry, I forget how many kids now we have in here. I think it's 16 kids. They were a median of 27 days at transplant, but they ranged out to 61 days. I will say our data is a little tainted because when we had a family that had a prior history and knew they were carrying an affected pregnancy, we brought them to Duke. We tested fetal lung maturity at 35 weeks. And if the lungs were mature, we delivered the baby and got that baby to transplant within the next 3 weeks or so, which meant they were really transplanted at an earlier gestational age than the typical newborn screening baby. And I don't know if that makes a difference. My gestalt is still earlier is better. And that it probably does make a little bit of a difference, but it's not going to be possible in the world we live in where we're finding out at prenatal, with newborn screening. And I'm not saying there's anything bad with newborn screening. I'm just kind of pointing out the difference. So we looked at survival in this group at 10 years. Again, it was 78.6%. And that persisted over time. We now have kids. I have a few that are 30. So a long time in follow-up. Then we looked at mobility, communication, feeding, prior to 30 days of transplant or after 30 days of transplant. And I'm going to find that curve. And what we found was that in the group transplanted by 30 days, the green is normal, the red is abnormal. There was a higher proportion of kids in the early transplant group who had normal mobility, communication, and feeding. So again, and I don't really know 30 days versus 31 days makes a difference. It's just the way our data fell out. Okay, but certainly 40 days is not as good as 30 days. 50 days we shouldn't be doing. So this is where that information about 30 days makes a difference, get the kid to transplant by 30 days comes from. Other functional outcomes, just to mention, all of these babies have very bad teeth. And when they get into sort of adolescence, they need complete dental reconstruction. The baby teeth either don't form or are terrible. And then a lot of the adult teeth are small or don't form or get early cavities. And really, they have a lot of problems with dentition. And of course, insurance doesn't cover this. It's very expensive. You can sometimes convince an occasional policy, but it's a hardship for the family. And it's something that we still have to overcome in terms of financial support. And when kids get to be adolescents, they care. They want, they want to look good. So it's really important. 70% of patients in both groups attended school, but in a lower grade than it was expected for their age, or they required special resources like an aide in school. And I think for a lot of these kids, and I say this as a transplant of kids with metabolic diseases, leukodystrophies, anything that makes you look different than your peers, there aren't really good social networks for these kids, and they need it. I don't really know how to do that. Again, I look kind of look to Hunter's Hope for maybe they have good ideas about that, but really these kids need the kind of support that they're not necessarily going to get in school. And as they get to high school and college, it's more apparent than it is when they're younger. So transplant after diagnosis through newborn screening. As I mentioned, there's the early experience with New York State, and then there's a later experience that many of us have collaborated on now. So Melissa Wasserstein published a paper in 2016 looking at the results of kids who had abnormal screening for Krabbe disease in New York State. And this just shows the algorithm. What's important to see is that there were 5, at the point of this report, there were 5 infants diagnosed with, in the day we called early infantile Krabbe disease, 9 with who were felt to be at high risk for Krabbe disease, but not early infantile. Of the 5 infants with early infantile Krabbe disease, 1 refused transplant. And I will say in that group, there are siblings. So the earlier sibling refused transplant, and then the family went ahead with transplant for the second sibling, because the first sibling developed symptoms and they realized, I think, more about the disease. Of the 4 who got transplanted, 2 died of peri-transplant complication, and there are 2 survivors who are now close to 13 and close to 18 years later. They both are impaired, but they are surviving. And the very first child who comes to Hunter's Hope pretty often, his name's Elmer, he's been adopted by our community. I will just say, anecdotally in my life, he's the first kid who went to school living in the Ronald McDonald House, because you're not allowed to have a Ronald McDonald House address when you first go to school. But it was socially, these families were very complicated. This family was undocumented, non-English speaking, a whole bunch of other challenges to work on in the setting of trying to bring a kid to transplant. And there are the 5 kids on the top. I'm going to come back to this a little bit later. I'm skipping a little just because of time. We then, in 2022, published a group of kids that we brought together, and many of you are on this paper, but from Nationwide and from Lurie and from Duke, and who else am I forgetting? May have been those 3, who were diagnosed through modern newborn screening and who got to transplant in the first month of life. And what's important to take away from this slide, which shows you in different colors by day, when they were admitted, when they had their consult, when they started chemo, and when they had their transplant, which is in red, that bar is 30 days. And you can see only 1 child, which is Dieter's kid from Kentucky, got to transplant before 30 days of age. And that was in spite of everybody's best efforts. The rest got to transplant between 30 and 40 days because of the obstacles that we've been talking about all along. In spite of that, and I think I mentioned, but the cytosines, which are in the second darker bar, ranged from 24 up to 73 on the newborn dried blood spot. And the mutations are there. I'm not going to go through all that. I will point out every child had evidence of active Krabbe disease on neurologic MRI or neurofunctional tests. So nerve conduction and MRI were the most common, but a few had abnormal EEG or Bayer's, and no baby was transplanted without evidence of active disease. all babies engrafted. The time was 12 to, I think, 24 days. All babies had full chimerism post-transplant initially. And no baby had serious graft versus host disease or other complications, and all babies are surviving. When we first published the paper, we showed neurofunctional outcomes done by Katie Gustafson at our team and then others at the other institutions. And the take-home message here is in panel B, where again, you can see motor function was affected. That's the bar that's really low, point right there. But cognitive and other functional status was good. And you'll see some of these kids here during the meeting this week. This just shows you nerve conduction. Margie did a lot of this analysis, Margie Ream, and they all have abnormal nerve conduction. Most of them had abnormal nerve conduction at birth, but it persisted over time and got worse. I will say, and Margie, you can, I hope, support what I'm going to say, but it's really, really hard to measure nerve conduction in young babies. And it's really, really hard to standardize the measurement of nerve conduction in any given kid from one test to the next. And then in different institutions, it's even crazier. And what we found early on, if the baby had an IV in one hand, they didn't do that hand, right? Or they didn't consistently measure left arm every time or right. I mean, it's all over the place, and it really needs a lot of work for us to make more detailed meaning out of it. But the truth is it's abnormal in these kids, and it becomes more abnormal over time. We had a follow-up study done by Katie Gustafson at Duke. This was requested indirectly by people at HRSA when we were going through the process of nominating Krabbe for the RUSP and following up. And so 5 of the 6 kids were studied remotely by administering Vineland's by Zoom. And then we added one other kid from Ohio who had been diagnosed since we wrote the paper and was available for testing. And again, we saw the same result. Motor function is affected. The other functions are pretty normal. And this is an ongoing kind of, I mean, it is the outcome with transplant, and it's the reason transplant's not curative or perfect. But it definitely makes a difference. And the hope again is adding gene therapy will make it even better. I want to just present a case study. People talk about the New York twins. And I think they illustrate some very important points. These are fraternal twins who are now 7. So they were born 7 years ago in New York State. They both had positive newborn screening, and Joe mentioned them. Their cytosine was 8. They had mutations that had some known disease-causing mutations, but some that were new. And they had a very high clear score, very low enzymes, and we were all very worried about them. We followed them with testing in the first month of life at Duke, and everything was normal. We followed them turned out to be 4 months by bringing them back to Duke and doing all those tests again. And at 15 months of age, it happened to be a boy and a girl. The MRI changes were seen in the boy. And so we brought them back, planning to proceed to transplant, and it took us about a month to get them back. By the time we brought them back, the girl also had MRI changes, which she had not had a month earlier. They both had elevated CSF proteins, and their nerve conduction was abnormal. We transferred them at 16 months, the standard way. They did well. Now they're 7. I didn't update this slide. And they're really doing quite well. This is cytosine that levels in their dried blood spots and CSF that Dieter followed over time. The scales are low. So on the blood spot, it goes as high as 6, and on the CSF, it goes as high as 0.3. So they bounced around a little bit, but even at the point where they clearly had active changes on scans and nerve conduction, their cytosine did not go up. And I was lucky enough to see them, I think it was last week, at Duke. It took a long, with COVID and everything, we couldn't get them back. But we got them back and they are doing great. The girl is just sitting because she's sitting, because she can't stand. They both just finished first grade. Motor wise, they don't have any issues. The little boy plays every sport you ever heard of. Their growth curves are normal. They're not small. They don't have great teeth, as I mentioned, but they are really. I mean, if you met them in the street, you would not know they had Krabbe disease. So I think they illustrate what we can do when we follow these kids closely. And it's hard to know who to pick to follow this way, but when you get the right group or the right patient, it really can benefit their life in a very significant way. I'll just say Maria also reported long-term outcomes of kids with late infantile Krabbe disease, which the twins fit into the category of. And again, the theme here is one, their survival is better, and two, that their function is much better than an early infantile kid. Although they can have peripheral neuropathy, it doesn't seem to progress as rapidly. And overall, if I have a family where the one boy is 20 and one is 22, and I think I have their picture at the end, but they walk, they talk, they're much more functional and much more independent than an early infantile kid would be at that age. And I guess I should just mention, there are a few juvenile cases. It's rarer, it's much more slowly progressive. We have 6 patients at Duke, and Bill Crivet reported 5 cases years ago. There isn't long-term follow-up on all, but at Duke, 4 of our 6 patients are surviving. Now it's really 7 to 21 years. Okay. I think for sake of time, I'm going to skip my DUOC part. My watch is talking to me. Okay, because we're doing something with cell therapy, but we don't have time to talk about it. So let's see. So what's the future going to bring? One is the gene therapy, which we are studying now and hope will actually improve outcomes of transplant. My prediction is it's going to have to be done early, just like transplant, but that it will help the peripheral neuropathy. And that maybe in a few years, we'll be standing here saying that standard of care is transplant followed by gene therapy. That will require a lot of developmental work and a lot more gene therapy to be available to give to patients. There are other smaller initiatives to try to improve engraftment in the brain after transplant with different chemotherapy drugs, and to combine other cell therapies with transplant or gene therapy. And I'll stop there. There are hundreds of people to thank, both in my own program and in the people we've collaborated with. And Hunter's Hope, who's been supportive all along, Krabbe Connect, Tilo, patients and families, and Maria, Mike, Dieter, Joe, Kristen Page, Margie Green, Rob Stone, and Tony Filiano, who's a guy in my lab who's doing a lot of preclinical work on improving outcomes of Krabbe disease. And then some of what I showed you was funded through the Robertson Foundation and the Marcus Foundation, which have funded a lot of the work that we have done over the years. So I'll stop there and see if you guys have any questions.